Okay, for chapter 15, this is on feeding and eating disorders. So let's go ahead and get started on this one as well. Um, Basically, in this chapter, I'm going to discuss the different types of feeding and eating disorders that you'll see, but I'm mainly going to focus on anorexia and bulimia because those are the two most prevalent ones that are out there. But when we're talking about eating disorders, it's alterations in normal eating patterns marked by persistent disturbance in eating behavior, weight regulation, or perception towards their body and weight shape. Now that's how it's defined in the DSM-5. Some categories that you'll see in the DSM-5 that are addressed under eating and feeding disorders are anorexia nervosa, and again, that's the unrelenting fear of weight gain, preoccupation with food or refusal to eat, and persistent behaviors lead to weight loss. So these behaviors here that they're talking about will lead to weight loss. Another one recognized is bulimia nervosa. This is repeated binge eating and purging. So this is the repeated stuffing yourself and then throwing it up. And then there's one called binge eating disorders. This doesn't have the purging with it, so that's why it's not bulimia. Binge eating is eating in the absence of extreme weight control. These people don't binge eat to lose weight. They just binge eat. Patients may be overweight, obese, or normal weight. They just eat too much at one time. There's one basically called other, specified or unspecified. This is when symptoms don't typically meet full diagnostic criteria. Purging disorder, not eating disorders. These are syndromes that the American Psychiatric Association have noticed, but they've not fully developed into full-blown disorder at this point. And under this other falls pica, persistent eating of substances other than food, rumination disorder, repeating regurgitation of food, avoidant or restrictive food intake disorder, and that's supported by weight loss. But what you have to know about all of these eating disorders is chronic, debilitating in nature, significant impact on the person. And because they have, if you don't eat right, then you know you're going to have some debilitating physical injuries. And that's what is most important with these. Some issues, just things that you need to know. Dysregulation of hormones are difficult to overcome when we're not eating. Our hormones are not being produced properly, so we got some issues going on with the hormonal imbalance in our body. Negative peer influences often add to the hostility in the recovery environment because negative feedback. Average age for anorexia is 19. Average age for bulimia is about 25. And eating disorders particularly concerned, it's a concerning thing that we really need to focus on if it happens really young, because so much is happening in the body developmentally between these ages that it's of a particular concern at that point. Some manifestations of anorexia: food restriction, unrelenting fear of weight gain, disturbed perception of disturbed perception of weight and shape, and excessive exercises. So these are some of the things that you'll see with people with anorexia doing. They'll restrict what they eat. They might limit their food intake to a very, very small amount. They have an unrelenting fear of gaining weight. That fear never goes away. And they have that disturbed perception of weight and shape. They're always heavier than what they think they are, and their shape is always out of proportion. They might think 97 pounds is extremely obese. And then they're always excessive exercising. They're always exercising because they don't like the way they look. It's a disturbed perception of weight and shape, disturbed perception of the way they look. When they get into these semi-starvation states, which is what they're doing, depression, irritability, excessive preoccupation with food, rituals, and later impairment of their cognition can happen, because you have to have nourishment for your body to operate, and if you don't, you have these situations, and there is a high morbidity and a high mortality rate associated with it. Bulimia, how it manifestates. They have a pervasive devaluation of self-worth. Their self-esteem is extremely low. They loathe the weight and the shape of their body. They can't stand it because of that self-worth. That's different than anorexia. Anorexia has a distorted perception of the way they look. Bulimia has a hatred of their weight and shape. It's not distorted. They just don't like it. They have a depressed mood, and they have a really big drive to have perfectionism and control. Results in those patterns of binge and purging. Of course, binging is the way they cope with stress, and the purging behaviors is the vomiting, the laxatives, and those type things. Binge eating disorders, how it kind of presents. Recurrent episodes of binge eating, which means they have episodes where they sit down and will eat. Now, these people aren't worried about the way they look. They're not worried about the way their body's shape and those type of things. They just have periods where they can't stop eating. They have a distress over the amount of food that they consume, and that results in that lack of control. Collaborative care. So, what do we do with these people as a group? Because they have so many physical problems going along with the psychosocial, we have to have coordination with physicians, dentists, because we'll talk about this in a minute. But with anorexia, you have destruction. With bulimia, you have destruction of the enamel, and with anorexia, you just don't have the healthy body to maintain, proper teeth. Registered dietitians, you have to have those on board. Mental health professionals, we have to deal with these underlying issues, as well as school personnel, because we have to know what's going on at school, because 8 hours a day, most of these people are out of our sight. Level of care, we want to begin with the least restrictive outpatient treatment. However, because there is so many physical issues that arise with these, we do normally increase to an inpatient environment. Restore patient to healthy weight, treat any complications, and reestablish patient social engagement. That's our goal of what we really want to do. With inpatient treatment, a little bit more intense, weight restoration through establishing a target weight in rates of gain. When a patient comes in, we'll say, our target goal for you might be 110 pounds, which means I want you to gain a half a pound a week. So we got to have those target weights and goals. Sometimes, patients are very hard to establish these target weights and gains, because that's their big fear. So we have to work through those fears. Nasogastric tubes are rarely used, and they're normally only reserved for people who are unable or unwilling to ingest nutrients. So nasogastric feeding tubes are the very last resort. Observe for evidence of fluid overload. Create a group or a nurture on the floor that we want to nurture these patients back to health. We don't want to endanger any more emotional facts that the patients or symptoms that the patient already has. Again, anorexia carries a potential life-threatening and physical or psychosocial complications because they're basically starving their body. It's more life-threatening than what bulimia is. At least with bulimia, they are getting some nutrients. The bulimia is just really hard on the regurgitation. That's where the physical ailments come in with bulimia. However, with anorexia, it's not. The body is basically just starving itself to death. Decision to hospitalize based on clinical presentation and available treatment options. And there are 4 classifications. Don't really need to worry about the classifications, but there are 4 levels of classifications. Here's a box that basically explains the criteria for admission for inpatient for eating disorders. So you can kind of see, again, these are very strong physical signs such as weight, 85% of estimated healthy weight, heart rate, below 40, blood pressure below 90/60, electrolyte imbalance, renal, cardiac, and other imbalances, suicidal tendencies, arrhythmias, failure to respond to least restrictive treatment. So you can see, the physical issues that anorexia does present. Inpatient treatment, we want to target weight being restored by establishing, again, those target weights and gains. Initial intake amount is established and may be increased gradually. So, patients have to know up front. Remember, patients are the one in mental health that are doing the interventions. I'm not doing these to them. I'm not assuring that they have IV fluids and this. They are the one that has to eat. So we have to make sure that they're okay. An initial intake may be you're going to eat 1/4 of what's brought to you. And then that's increased gradually. But we have to make sure that is a goal that patient can attain. We monitor vital signs, intake output, electrolytes, signs and symptoms of fluid overload. Refeeding syndrome is basically shocking their body with nutrients and stuff that they've not had before, so it pushes the body into some other physical issues, GI, cardiac functioning. So we got to monitor all of those. So on the physical side, we pretty much know what we need to do. But what on the mental side? How are we going to treat their disturbed thought patterns that they have? Formal psychotherapy starts once the weight gaining begins and the patient's able to participate cognitively. We have to get them physically stable. Remember, we treat the medical before we treat the mental. APA has practice guidelines out there on how to treat patients with eating disorders. A lot of research and time has been done to how do we treat these patients effectively. Family approaches is the most effective. Everybody needs to be involved in it. It can't be just treating one person. Everybody has to understand the rhyme and reason behind what's happening. Different treatments: core pathology, over evaluation of body shape and control of body weight. That's one way that we provide some therapy. In core therapy, in bulimia, patients fail to adhere to the efforts to restrict their eating. That's not normally the best that we choose. The one that's widely used besides the family approach is cognitive behavioral therapy. It's most widely used form of treatment for eating disorders. It's strongly supported as the single most effective intervention for treating, especially bulimia and binge eating disorders. So that's the one that you will see most. Remember, with that, we're working with changing the way they think as well as changing their behavior. CBTE is enhanced. It's basically aimed at anorexia. And basically what the enhanced version is we're having to incorporate in those cognitive behavioral issues, not necessarily thoughts and behaviors, but we're addressing dietary rules, involving significant others, establishing regular weight eating. So it's specifically aimed at anorexia nervosa. Psychopharmacology. Again, we don't use therapy alone. Most of the time we have to use some sort of psychopharmacology. And basically what that involves with anorexia is some SSRIs. That's what's been most effective that we have seen. TCAs and MAOIs should not be used. with patients who are considered underweight. There's some issues with those that we don't like to use, because their overall potential for lethality and toxicity and overdose should be taken into consideration. So we don't want to use them in underweight patients. Second generation antipsychotics can be used again, but they're most effective with those with the severe symptoms of anorexia. So we're really focused on those serotonin, selective serotonin reuptake inhibitors. Those are the ones that we use most with anorexia. For bulimia, we use Prozac. If you remember back to when we were discussing bulimia, we have the binge, which is the stress alleviating behavior, and then the purging, which is the behavior associated with the binging. If we think back to obsessive compulsive disease, that's kind of how that works. You have a compulsion and then an obsession. One is the obsession is the thought, the compulsion is the behavior. Same way with bulimia. So that's why Prozac works really well. Prozac works good for those type behaviors and those type disorders. So most effective at 60 milligrams to reduce those binging and purging attitudes. Other SSRIs have shown effectiveness, but it's the Prozac that normally deals with that has an obsession and a compulsion, or a thought and a behavior. We can use Zofran. Again, that's just an antiemetic that decreases the time spent engaging in bulimic behaviors. Zofrans that will not allow that person to vomit as much. Initial treatment with Zofran was not considered a viable option, in part because the multiple daily doses and the cost of the medication, and again, FDA had not approved it. However, use of that is currently available in a generic form and may be feasible treatment option. So hopefully that's something that we can use in the future. Combining these with cognitive behavioral therapy is what has been the best in reducing binging and vomiting, because medication alone will not stop this behavior. Binge eating disorder, what we're using there basically is Xenical, dose dependent reduction on dietary fat absorption, plus CBT leads to better results with the binge, just as the binge eating disorder. So what are we going to do? Combination of food restriction, you know what anorexia is, that's the definition here. Physiological characteristics occurring secondary to weight loss include poor sleep, sensitivity to cold, sensation of fullness, decreased energy, poor nutrition, which is what cachexia is, or malnutrition, GI disturbances, anemia, skin and hair changes, loss of menses, muscle cramps, bone pain, arrested growth, osteopenia, osteoporosis. So you can see just by going down this list what physical ailments that anorexia nervosa can present and cause in a body. Weakness, fatigue, increases with a degree of malnutrition, and limited motivation due to the egosyntonic nature of the illness. This is also in your book, but here's the table. It basically gives you the symptoms associated with the body system. So you need to make sure you review those and understand, what's going on in that body when this person has anorexia. Bulimia, you already know that that's a pervasive, devaluated self-worth, loathing of body weight and shape, and depressive mood states. Many of the physiological effects are similar to anorexia, but they also have cardiac anomalies and loss of dental enamel due to vomiting. Essential to identify the trigger of the binge purging process. Remember, back to obsessive compulsive disease, kind of put these together in your mind. Even though binge bulimia is not obsessive compulsive, it still works the same way. There's normally a trigger that causes this person to have the stress or the anxiety that causes the person to binge eat. But because they have bulimia, when they binge eat, just like an obsessive compulsive person, there's a behavior there that has to happen, and that's the purge. So looking for the trigger helps people with bulimia nervosa. Some stressors can be interpersonal stressors, negative feelings about their body weight or shape. Maybe they woke up that morning, didn't like the way they look, and just actually boredom. The purging behaviors, again, what you see is vomiting. They can use laxative, diuretics, or insulin to make them purge what they ate, as well as excessive exercise. So what are we as nurses going to do? Again, there's nothing that we can physically do other than to monitor this patient's progress. Severe physiological damage to patient is there if it's left untreated. We have physical growth and maturation that's happening during this time, metabolism issues with the starving, as well as just critical organ function. The body's not getting the nutrition that it needs. The big thing first, treat medical before mental, address the physical complications first. If we don't treat what's wrong with these patients physically, it doesn't matter what's wrong with them mentally, because they're not going to be alive for us to do anything with. Priorities, managing weight, and stabilizing physical functioning. So big thing, observe and a good, strong physical assessment through medical monitoring, assessing the patient's distorted thinking patterns regarding eating calories, exercise, body image, asking those questions that try to bring this information to light. Determine level of impairment, what's going on, functioning within the family. A lot of times these disorders have some sort of family functioning distortion there going on. You know, overbearing parents, not feeling like they're meeting their parents' needs or expectations, relationships with peers, performance at school and work. So we got to assess all those things, monitor all those things, because all of those are the underlying reasons or causes for what's going on. So I told you to ask questions. Questions that you need to ask. Do you feel as though food controls your life? And in what way? Do you make yourself vomit after eating or using laxatives or excessive exercise as a mean to control your weight? Are you aware of anything that participates what brings these on? On a scale of 1 to 10, how do you feel that these triggers are? You know, when they identify the triggers, which one makes you worse? Which one makes you not as bad? Here's some common nursing diagnoses. Again, there's many, but these are just some common ones that you're going to use. Again, they're going to be patient driven as far as the symptoms that they present with. Some more here, but remember, when we're doing this, we want to collaborate with the patient. This is not something that the nurse comes up with alone. We have to make sure the patient understands what's going on. Often a patient is so concerned with weight gain that they'll do anything to prevent the weight gain. So you have to keep that in mind. So it can be difficult or impossible to collaborate with them. Nurses should address the most significant patient need based on your observation and measurable symptoms. These people are not going to tell you the truth right up front until you gain that nurse-patient relationship with them. So you have to assess and monitor what you think is best and go from there. Plans and goals need to be specific, realistic, and measurable, addressing the 5 behaviors or the 5 domains that we see: the physiological, the biological, the social, those type things. And a patient education is very important. So you have to have that in your planning as well. The patient needs to understand, and we have to educate them on their abilities. So you have to assess their learning needs and willingness to learn. Some implementation, some things that we're going to do: stress reduction, educate the patient about possible stressors that contribute to the behavior, those triggers that they have. Does not directly confront the problem, but can foster therapeutic relationships. So you have to make sure you address those. Decrease the exposure to the environmental stressors. How do we decrease that? Maybe they need to move away from a certain group, stop running around with a certain group of girls or boys at school, and eliminate caffeine and other stimulants. We want to teach methods of self-soothing. We want to do some stress reduction interventions, some guided imagery, whatever that we need to do to teach them how to reduce their stress. Encourage them not to use the drugs and alcohol. Frame suggestions in ways that does not directly confront a behavior, but the patient does not have no desire to change. And begin to offer information concerning treatment. So we got to look on, we got to address on, this, on how to self-soothe, how to work with your stress reduction. Don't self-medicate. When we're talking, we want to frame suggestions in a way that doesn't directly confront, but kind of come around the back door. Remember, these patients have a very strong wall in front of them when it comes to ideas of weight gain and weight issues. So we have to kind of come around the back door and begin to offer information concerning treatment. Bulimia, identifying those triggers is the big thing. We have to understand what sets them off. 39% of a study participants cited interpersonal relationships as triggers. And that could be anything from relationship with boyfriends, relationship with families, whatever that may be. But it's normally some sort of trigger that sets this person off to binging. 61% noted a turbulent inner emotional state as a trigger of relapse. Negative statements such as anxiety and anger also drives them to binge. So they use the binge as a way to deal with issues in their life, and we have to make them understand how to identify those triggers. Help the patient review events and feelings prior to an episode to try to pinpoint a trigger. Help them identify healthy responses. So instead of binging, what are we going to do differently? Instead of going down this road, we're going to make a left turn and go down another road. Maintain emotional support at meal times. Be there with them. Let them know that you can eat a regular meal without binging. Help patients reframe that distorted thinking. And of course, we always have to monitor for the purging, because that will go on and they can get very, very sneaky with it. Promote feelings of self-worth and positive regard. Remember, both of these disorders have a distorted thought process of either the way they look or a hatred for the way they look. Patients with anorexia, they contribute self-worth to thinness, so they're more self-worth, or they have more self-esteem the thinner that they get, and they have a quest for that perfection weight, whatever that it may be. Patients who are overweight during adolescence have increased attention and positive regard following that weight loss. If you have someone who was overweight during their adolescence years, become bulimic when they're 15, 16 years old, we have to give them a positive regard for following those things. Always want to promote self-worth and positive regard. Remember, that's a lot of driving force behind these disorders. Help a patient set short-term goals, realistic goals, so they can meet them. Once they meet one or two little goals, that builds that confidence, that builds that self-worth in that patient. And encourage them to reconnect with activities that they enjoy. Again, making them happy, making their self-worth and positive regard easy to attain. We always want to revisit during recovery and rehabilitation. Make sure that we have a good plan set forth. Provide education when reduce frequency of problem behaviors. Make sure that we're addressing those concerns and issues that arise. And again, evaluation, always with goals, looking, are they met? Can they be met? Are they partially met? Including time frames and measurements. Examining treatment goals that affect the course, severity, and duration of illness. And always remember, patients experiencing pervasive devaluated self-worth, loathing of body weight, shape, continually live in fear. They're continually suffering for whatever reason that it may be. And treatment needs to be gained or guided of eating disorders because the disease is so complex and it's so poorly understood outside the medical realm. So we need to know the components involved, accepting through spirituality, increasing self-worth and hope through other aspects of patients, a patient's being the body weight and shape that is healthy for them. So we have to make sure that we help the patients get there.